The following is a paid advertisement of St. Anthony Hospital Orthopedics. References to any specific product, services, or entity does not constitute an endorsement or recommendation by St. Anthony Hospital, Carroll Broadcasting, or its advertisers. The views expressed by the host or guests are their own, and their appearance on the program does not imply an endorsement of them or any entity they represent. Welcome to the St. Anthony Hospital Orthopedic Show with Dr. Richard Godding. Dr. Godding specializes in joint preservation, reconstruction, and replacement surgery, and brings over 25 years of orthopedic excellence to St. Anthony Hospital and to the Carroll area. For more information about Dr. Godding, his practice, or St. Anthony Orthopedics, go to santanthonyhospital.org or make an appointment by calling 712-794-5536.
Good Sunday morning, Iowa. It's Dr. Rick Godding. Thank you for choosing to spend a little bit of time with me here today. And I want to do a little bit of housekeeping. First of all, I haven't mentioned as often as I probably should have that I am at Audubon County Hospital every week now. So I go alternating Wednesdays and Thursdays. I have clinic out there. I do surgeries there. Mostly arthroscopy and some small fractures, small rotator cuff repairs, things like that. You know, the joint replacement I still do at Carroll because, of course, we have the Mako robot, which we're going to talk a little bit more about today. But I am at Audubon. So if you are, I don't even know if WHO and KCIM reach out past Audubon towards Atlantic. It seems KCIM does. So if you're out in that area and you want to come to Audubon Hospital, I'd be happy to see you there so that you don't have to drive too far. And then Dr. Dirks and I are doing a community event here in Carroll on Tuesday, February 18th from 5:30 to 6:30 at the Santa Maria Winery. We're going to talk about joint replacement, and he's going to talk about hips, and I'm going to talk about knees, and I'm going to talk a little bit about the history of the Mako and robotics in general, and he's going to talk about the joint replacement experience at St. Anthony's. There will be appetizers and refreshments. Free. The event is free. So if you would like to come and meet Dr. Dirks and myself, or just listen in and have some snacks at the Santa Maria Winery on Tuesday, February 18th from 5:30 to 6:30 p.m., please come join us and learn a little bit more about joint replacements and meet a couple of really nice orthopedic surgeons. So last week, I started in my what essentially will be now a series of sort of where's technology in orthopedics in 2025. And I started out with joint replacement, and I talked a little bit about the Mako robot and the differences between the Mako robot and the traditional way of doing it, meaning the metal jigs that either one of them goes up into the femur and we make a cut based on that as a reference point. And then the other one is a jig that goes on the outside of the tibia, the shin bone. And we kind of line that up and eyeball it and make a cut there. And, you know, it's amazing how well we did with that type of knee replacement, with the non-robotic knee replacement, because, I mean, the level of accuracy that you can get to is really not even close. As a matter of fact, the old books would tell you that anything, when you're measuring with these jigs, you have a plus minus 3 degrees. So you really could be off in either direction by up to 3 degrees. So it didn't make any sense to try to measure anything to 3 degrees or less. Now we get to the 1 degree because we're exactly. So obviously the knees, and even more so hips, are very forgiving. Knees are forgiving. I know back in the day when I was using the standard metal jigs without the robot, I had some x-rays that I just couldn't believe the patient was doing well, but they were doing very well. Now all the x-rays are exactly like we want them to be afterwards. And, you know, I'll go back a little bit. We were using specifically what's called mechanical alignment, and that's where you line up the knee replacement with the leg in mechanical alignment. So basically a plumb line from the center of your hip to the center of your ankle. Boom, those are where the cuts go. The problem with that is that that's not how everybody's knees are. Everybody's knees are off a few degrees, 2 or 3 degrees from each other. I mean, you see people that are a little bow-legged, a little knock-kneed. So everybody's knees don't start out the same. So to cut everybody's knees the exact same and then release ligaments so that you balance it out doesn't make as much sense as cutting the bone exactly to that person's personal anatomy. Now, there's even a thing out there where they do what's called a personalized joint replacement, where they take a CT scan and then they make a joint replacement for your particular knee. Well, I'll tell you a little secret about that. It's not like they're 3D printing a knee. They basically just have a lot more sizes, and they just grab the size and shape that's closest to yours. So they may have 100 versus 10 sizes, but it's still, they're not manufacturing it for your knee. The jig to put it in, they are manufacturing for your knee. But again, that doesn't take into account the ligamentous balancing. So, the only way to get the ligaments to be perfectly anatomic is to, while you're in the operating room, put the ligaments on the exact amount of stretch you want them and cut the bone there, instead of cutting the bone and then loosening the ligaments as you need to. And so I know it's kind of technical. It's a little bit difficult to get how that works across, but just understand we're starting with a 3-dimensional CT scan. So instead of just X-rays that show the front and the side and the sort of what we call the sunrise view, we have a 3D CT scan. You can literally rotate it around in any direction, and you see exactly every little bump, every nook and cranny. This is not inherent in all the robots. This is the Mako. The other robots, a lot of the other robots, I think all the other robots use an X-ray. And none of them have the depth of capabilities for ligamentous balancing that the Mako does. And some of them aren't even robots. Again, I'm not throwing other brand names out there, but there's one brand out there that calls itself robotic, and there is no robot attached anywhere. It just has nothing to do with robotic. I don't know how they're allowed to call it robotic. What it is it's a handheld cutting device that has reflectors on it, and then you're looking up at a screen and you're making a couple holes, and off of those holes you put the standard old-fashioned metal cutting jig and then make the cuts off of that. And with the Mako, you put in exactly where you want the cuts done, and the robot arm comes out, and I'm guiding it, but it's only going exactly where I said it was going to go, and it cuts to the degree and to the millimeter. And we've already put in your ligamentous balancing. We've put the ligaments in the exact balance we want them before we make any cuts in the operating room at that moment, backed up with a CT, and we snap essentially a picture of that within the computer that we're looking at, and then the robot arm comes out and we make the cuts exactly to where they should be. And I was saying last week, I used to have to manipulate, so you'd have what's called a manipulation under anesthesia, where the knee just wasn't bending after you did the knee replacement. So 6 weeks, if it's not bending to 90 degrees, we put you to sleep in the operating room and don't make any cuts or anything, just push on it. I used to do that weekly. It's 5 to 8% of my patients, and then that's pretty much everybody. But I've done 2 of those since I started at Carroll. This is my 5th year. I'll be 5 years in August. I've done somewhere between 500 and 600 knee replacements here. And I've done 2. So that tells you there's a dramatic difference. And all of the outcomes data is starting to really favor robotics. Robotics is going to be the only way to go. And again, the problem is that the robotic platforms are not created equally. There are other robotic platforms out there that are essentially free, or 100,000 or 200,000. The Mako was 1.5 million. And again, the St. Anthony's administration said, "What do you need?" I said, "I need a Mako robot." And they said, "What is that?" And I said, "Well, it's a robot that's going to make joint replacements just way better." And so they went and got it. And then, of course, Dr. Dirks came here, and he trained in his residency, which is the training you do after medical school. He trained in his residency on the Mako, and so he was already a Mako guy. So now we have 2 Mako guys, and so that's really great. And so all right, so I've gone back over the Mako robot as where is the state of the art. And last week I talked about the improvements in both the design of the knees and hips and in the improvement of the materials, particularly the plastic, which is wearing much better. Because the metal on plastic, the knee is metal on plastic, and it is going to wear to a certain degree, like everything else, just like anything is going to wear. Two hard surfaces on each other and rubbing all day, they're going to wear, but it wears dramatically less than it used to. And that has allowed us to have a lot more confidence that, we're putting knees in people in their late 40s, early 50s, and I tell those patients, I think it's unlikely that they will need that knee done again based on my recent experience. When I first started in 2004, and I started my residency in 1998, and we used to do revisions every week because you have all these knees coming in and the plastic was worn out, and so the knee became loose, and then you'd have to redo it. But now you just hardly ever see it, because about 25 years ago, the change in the way that the plastics were processed improved their wear rates dramatically. And then, of course, you have the improvement in the designs themselves. And then, of course, now we're putting them in more accurately with things like robotics and navigation before that. So, it's really, really come along. And so what are the other things? What else has changed? Well, pain. I mean, the approach to pain when I started. So when I was a resident in 1998, if you had a knee replacement done, you were there for 3 to 5 days. We put you on Coumadin, and we'd try to get your Coumadin, which is a blood thinner, to a certain level. And then you would have a button you could press to give yourself morphine every 5 minutes. And then you'd have Tylenol, and that was it. And basically, through a lot of different categories of improvement, we now don't do anything even like that. And a lot of people go home the same day. I prefer to keep people overnight because I think that, especially given that most of my patient demographic is 60 or over, if someone says they want to go home after a knee replacement, I don't say no, but why would you? To me, it's just, there's no data that shows that it's better to go home. The best data shows that it's only a little tiny bit worse, if not equal. And so the majority of the studies are showing that you have equal outcomes and equal return to surgery and all that stuff. But if I'm having a knee replacement, I wouldn't mind staying overnight in the hospital. Now, as you get older and you have more other medical problems, like if you have diabetes and high blood pressure, I want you in the hospital overnight. I want to watch, because every once in a while something goes awry medically, and I like to have a nurse right there. So what we do now is we have what's called a multimodal pain program. And of course, I start with using the iovera treatment, where you freeze. This is a freezing of the nerves on the front of the knee a couple weeks before the surgery. That's the same day you would come in and get your CT scan for the surgery. And then we're going to give gabapentin, Celebrex, Tylenol, and a bit of oxycodone, just a little bit, like 15 or 20 of those, as opposed to we used to give 60 or 80. And then a topical lidocaine and anti-inflammatory cream. We're going to get you, instead of laying in bed for the first 24 hours, we're getting you up and moving immediately. Like a couple hours after the surgery, you should be at least doing exercises, if not sitting on the edge of the bed or standing or walking to the bathroom. A few hours after the surgery. We wouldn't even have thought about that 25 years ago. And that has led to the dramatic decrease in the number of blood clots. And so now, instead of using Coumadin for everybody, which is a very powerful drug, and there were some studies that showed that more people died from Coumadin than died from blood clots after knee replacement. And when everybody was using Coumadin, because, if you have any little bleeding, like a bleeding ulcer that starts or something like that, or a bleed in your brain or something like that, if you're on Coumadin, it just goes crazy and you can't stop it. And then people were dying. So people were dying from the attempt to prevent them from dying from blood clots. So they were bleeding. This is back, and Coumadin is still a good drug for some people if they have atrial fibrillation, but you don't want to be putting everybody that has joint replacement on that. We now every orthopedic surgeon I know uses just aspirin now, unless you have an additional high risk factor for a blood clot, because aspirin has been shown to be perfectly safe and perfectly effective. It's not perfectly, nothing's perfect. I shouldn't say that. Extremely safe and extremely effective. Combining that with getting up early and moving and all the other things, devices that we use that squeeze your calves. So that's sort of that aspect of it. And now, I talked a little bit last week about vitamin D supplementation and essential amino acids and probiotics. I'll just review that quickly. So vitamin D supplementation, lots of people are vitamin D deficient, and there's new studies that show that vitamin D deficiency reduces your chances of having a good outcome after a knee replacement. And so we are now testing for that, and we will supplement if we come across people who are deficient in vitamin D. So once again, take a multivitamin. I think that's good for your health. I take a multivitamin every day. I think everybody should, especially as you get older. Essential amino acids are the amino acids that your body can't make. You have to take those in your diet. If you're over 50, you probably should be taking essential amino acids every day. I would say a protein supplement, but gosh, I just read this article about how a bunch of protein supplements have heavy metals and cancer-causing things in them. I don't know. Who knows? Everything's scary. but you definitely need protein, and essential amino acids are a good way to get that protein or the building blocks of it. So we're putting people on essential amino acids, supplementing their vitamin D if they need, and then also probiotics, which again are the bacteria that help get your gut balanced. And so there are particular bacteria that, one of them is called bifidobacterium, and we want you to have a lot of that particular one in certain areas of your gut. So you take those pills. And so those things, those metabolic things are part of the state of the art of what is happening in joint replacement. And, the essential amino acids, there is a study that shows that it reduces the amount that your thigh muscle shrinks after surgery. So these are things, essential amino acids, probiotics, and vitamin D. I mean, those are easy, inexpensive, essentially as close to 0% chance of harm as you can get. We're trying to stack the deck in our favor with every joint replacement we do. So another thing, I went over the pain control modalities that we're using, the multimodal pain control, instead of just pressing a button every 5 minutes and getting morphine, which was no good for anything. Now, we do the multimodal. The other is infection control. When I was a resident back 25 years ago, we had just started using we call them space suits. So it kind of looks like you're in a space suit. And so now the technology on those has improved. And so what it's doing is it's trying to keep as much contact away from anything coming off of your body, skin flaking off or whatever. And so the next thing that came about was what we call positive pressure ventilation. So now in our ORs at St. Anthony, we have the latest technology. It's called positive pressure ventilation. And it pushes the air in one direction so that when the doors are open, that everything goes out. And so there's not recirculating air flows within the OR. So if there's a bacteria floating around, and there's bacteria everywhere, no matter how much we clean. So if something is floating around, it's not just doing circles in the air and maybe landing in the knee or hip. So that's another infection control thing that we're doing. Another thing that we're doing is we have two different solutions that have different mechanisms. One is called chlorhexidine gluconate. So we're preparing the skin with that, not just the day of surgery, but we're using that soap and shampoo made of that for an entire week before. And so that really reduces the amount of bacteria on your skin. And then a little antibacterial ointment in the nose, and then the space suits, the positive pressure ventilation, and then two separate washes of two different types of, I shouldn't say antibiotic, antimicrobial fluids. One of them is that chlorhexidine gluconate again within the knee, and then wash it out. And then there's another one called Prontocin, and that is what's called a surfactant. And so that is supposed to, if there's any bacteria in there, it kills them. And if it doesn't kill them, it at least stops them from attaching to anything so they can just get processed by your body. So the other thing is the incision closure. So we used to use staples, and I always hated staples because people hated them when you took them out and they hurt, and then they always had these little red circles around where the staple went into the skin. So now we use what's called subcuticular closures. So we run one suture under the skin, and so you don't need anything on top of the skin. So everything's under. And that affects not just your recovery and how you feel, but it also affects the infection rates. And infection rates have gone down from 2 to 3% to about 1%. And that's nationwide. Somewhere between 1 and 2 is where everybody is. And we are very, very low. We're below 1% at St. Anthony's. I haven't had an infection for a very, very long time, well over a year. And these things that we're all working on all the time combined to have a joint replacement experience that is just completely different than it was even 5 years ago, but especially 20 years ago, but even 5 years ago. And, even today I'll have patients who come and I do one of their knees and they just say, wow, that was just so much less pain than I had last time when I did it somewhere else. And so all of those things come together, the not doing the ligamentous balancing because we're using the Mako robot, the multiple blocks that we do. We're going to give you a block. We do the iovera 2 weeks before, then we'll do what's called a adductor canal block. So we're blocking some nerves before the surgery using ultrasound to get to that nerve, and then a spinal anesthetic before the surgery, and then another block of what's called the posterior capsule during the surgery that we do. So a lot of lidocaine, a lot less morphine. So that's state of the art in joint replacement in 2025. And I'll be moving on to other subjects in the next few weeks. And if you would like a more detailed and visual and personal explanation on that kind of stuff, again, you can come to the Santa Maria Winery in Carroll. And Dr. Dirks and myself will be giving a talk with visual aids and some appetizers and refreshments. That will be Tuesday, February 18th from 5:30 to 6:30 if you'd like to get an in-depth view of the state-of-the-art in joint replacement with Dr. Dirks and myself here from St. Anthony's Regional Hospital. So thanks again for choosing to spend some time with me here today, and you have a blessed week, Iowa.
This has been the St. Anthony Hospital Orthopedic Show with Dr. Richard Goding. For more information about Dr. Goding, his practice, or St. Anthony Hospital Orthopedics, go to www.santanthonyhospital.org or make an appointment by calling 712-794-5536.